variabel aufgestellt wird.
Das stimmt, das erlebe ich schon auch. Also es gibt schon Sachen, die eher vom Haus unterstützt werden, zum Beispiel eben so Bachelor, so die Studiengänge,
Ja.
anders unterstützt wird. Aber jetzt bis auch kleine 1- bis 2-tägige Haus
Morning.
Good morning. Good morning, everyone. Good afternoon. Good evening.
Hi Renit. Hi Maxim.
Hello. Thank you, Ronnie. Thank you, Alan. Thank you for coming.
Yes.
Alan, I hope you're ready with some history.
Of course not. I just rushed in.
Oh, I like the view, Maxime.
Right. I don't know. It's bittersweet. But
good morning.
Good morning and good morning.
Nice slopes.
Next year, I hope. I think let's see. So maybe we just wait another couple of minutes, and after that we'll get started. Thanks for coming, everyone, again. Look forward to a great session. Hi, thank you.
Hey, how are you?
Thank you. Thanks for coming.
Ronit really has the last year's thing, huh? You and Ronit. Very good.
Found mine.
It's already 3 years ago, though. Or more.
That's right.
Hi, Kim.
Hello. Hi, Renate.
Hey, Alan and Kim.
What's happening in South
Hi.
Africa Alan, with the COVID?
Oh, it's really bad. Every bed is full. Every ICU has got a ventilator with a patient. It's not good at all.
Are you getting vaccines or not yet?
Yeah.
Any vaccines arriving?
Healthcare workers are supposed to get the AstraZeneca vaccine this month. So the first dose will, but it hasn't arrived yet. So we'll see.
Okay.
So,
Hello, everybody. Hello.
well, thank you everyone again for joining. Probably more people will be filtering in as we speak. It's as you all know, as you can see, we're dedicating this bananas to the ABC WIN meeting, and this is a time when many of us look forward to going there. I think it's the first time since almost 40 years. It's one of the oldest, probably the oldest neurointerventional meeting. Many of you know more about it than I do. I think it's the first time that it's not been held. But of course, we hope that it would be the last time, and we'll be back in 22. We have, as you can see, we have some guests. We have a guest panel of Ranit, Shankyu, and Alan from WFIT and Leadership. WFITN is the umbrella organization that under which auspices ABC WIN is held. We are honored to have them. I think this meeting has had an enormous impact on professional, personal development of many of us. And I think it's just fitting that I'm relatively new to this meeting too. So I'm hoping maybe you can say a couple of words about it. You can have something about the meeting, its impact, and what you feel the future might be. Maybe Alan, if you could start.
Yeah. So thank you very much for the invitation, Maxim. You're right. I think that meeting has had a tremendous influence on everybody who's been there and many people who practice neurointervention. The first meeting was actually not to do with the World Federation. It was 20 neurointerventionists from around the world who met in Santa Barbara. And that was the WIN meeting. I think it was 1989. And then the second meeting was held in Val d'Isere. That was 1990. And that was organized by Luc Picard. And it was the WIN meeting, the Working Group in Interventional Neuroradiology. And that's where the World Federation was founded in 1990. And we have that document on the website with all the signatures of the people who were there. And since then, the World Federation has had its General Assembly at Val d'Isere every year. You're right, I don't think there's been a single meeting that's been missed. And it was a little bit later that Pierre Legenius joined in with the ABC part of the meeting, and that's when it became ABC WIN. And the ABC was anatomy, biology and clinical correlation, which is really, I know that's where the inspiration comes for neuroangio.org, is from Pierre's books and the way he taught neuroanatomy. And you know, I'm absolutely thrilled that you've got such a collection of incredible cases, such a huge resource for teaching and learning. So thank you so much for putting it together. And the only other thing I'd like to say is this, something about the spirit of the world of the ABC WIN meeting, which is now organized by George Radesh and Luc Picard and Serge Picard and Luc Picard, is that it's always had this, because it started as a small group of people who were really just discussing cases, it's kept that spirit. And you're allowed to discuss anything. You're also allowed to challenge anybody on anything. And that spirit has been maintained even when there's 600 people in the room, that it's a very informal, friendly meeting. And I've made so many friends there. I'm sure you all have. I can't wait to go to the next one, and I hope it continues for a very, very long time. I think I'll stop there, otherwise I don't want to take up too much time, Maxim.
Alan, thank you so much. Thank you. I think we just open the floor. Ronit, thank you. If Kim, anyone, Dodi, there's so many people here that that you know that can say what this means to them.
Thanks for the invitation. I don't have much to add. Alan has summarized it nicely. But for me, I started attending the ABC meeting in Val at 2005. I've been going every other year or so. I can say for sure that most of the colleagues that, you know, most of my friends in this profession, for sure I met them in Val d'Isere because of the informal, you know, way this meeting is. It doesn't feel like any other meeting. I don't know any other equivalent meeting that's like that. Very friendly, from all over the world. The funny thing is that the first colleagues outside of Toronto I met was in Val d'Isere. So I actually met my Canadian colleagues, Daniel Roy and Alain Weil, at Val d'Isere in 2005. So yeah, you can, you know, it's very unusual that you can be practicing for 2 years or for 20 or 30 years, and you can say, you know, give your opinion. Your abstract doesn't have to be accepted, you know, in the usual fashion. And as an observer, you can learn from mistakes of younger people, older people, you know, in the profession. And I think it's it's an outstanding meeting, and no wonder it became so well attended.
Well, I don't have anything in add because the Alan and Ronit actually said very nicely, and the summary. I just want to thank you, Max, for organizing this wonderful venue. And I really appreciate that the you and the NYU team actually continue the core value and of the this World Federation and Val d'Isere. So I thank you very much. One thing that I'm just thinking about to add is as Alan said, it has been about almost 20 more years ago, and we had initiated that the Val d'Isere meeting, and that Val d'Isere meeting was exactly the current value of the diversity and inclusion. So that was wonderful. At that point, that's probably the first meeting including North America, Asia, Europe, and this whole continent involved. So I really appreciate and respect the father, the visionary, the view establishing WFITN. So I hope our current new generations also will join and enjoy this nice venue and World Federation. Thank you.
Thank you. Thank you. Thank you. Thank you, Ranit. Is anybody else want to say anything?
Hi, this is Dodi. I have prepared a few slides, if you care, about the Val d'Isere meeting, just a small presentation of my relationship with the Val d'Isere meeting. If you think it's okay.
Sure, you can share the screen anytime.
Okay, can you see them?
Yes.
Okay, so this is really the way I see the Val d'Isere meeting, and I've seen it for some time. So you have to go back to what was neurointervention in the 70s. It was really, bricolage. It was homemade catheters and devices, no microcatheters, no microwires, no coils. We only had detachable balloons and glue and particles. And with that, we did incredible things. And there were only very few people around the world doing it. So these few people, mostly French and Americans, decided it would be better to meet and share their experiences. And they did so. And the first meeting was in 1980 in Santa Barbara, Alan. And the second meeting was in Val d'Isere in 1982. And then since 1984, it was every year in the third week of January. So it's a very long time. And my first time was in 1986, and I did not miss once. So I realized I've been there for 35 consecutive years, and I couldn't believe it. This is a picture of the 1982 meeting. I don't know why I have this thing here. And you can see there were 19 people there. It was just case discussions, and there were heated discussion, I can't remember, but for hours and days about glue versus particles in AVM embolizations. And we would spend hours discussing. The Pittsburgh people were for particles, the California people were for glue. And so how to dilute isobutyl cyanoacrylate? We would spend hours thinking about it, and we would add lipiodol, but before it was acetate and all kinds of things. And discussing where to place an occlusion balloon in the ICA. It should be in the neck, should be in the petrous bone, it should be close to the cavernous sinus. It was just case discussions. We would use real slides. There was no PowerPoint. And I don't know how many people have seen real slides now today. And we would use 2 slide projectors side by side. Again, I don't know how many people have seen a slide projector. This is a slide projector. And with time, it became more sophisticated. So we had this slide projector, which is a carousel. And those square white things you see there, those are the slides. So there were no lessons, there were no lectures, no seminars, no boring presentations of series of cases, just case discussions. And one would learn a lot just from the discussion of single cases and from showing one mistakes. People from all over the world were invited and would eagerly participate. And this is a picture of Val d'Isere in 1987. And in the first line, you could see Picard, Moret, Terbrugge, Bernstein. And then there were some people from France, a lot. other people from North America, Canada, and US, Mexico. And then there were Italians, South America, England, Spain, Far East. In reality, one is in Subchoy, which is from New York. But anyway, so the ABC meeting in Val d'Isere, you called this today's, it's about the ABC WIN meeting in Val d'Isere. In reality, for me, it's a Val d'Isere meeting. We all say, let's go to Val d'Isere. I met him in Val d'Isere. You don't say I met him in the ABC meeting. And it became WIN around 1990. And you know what WIN means? WIN is Working Group in Interventional Neuroradiology. And then the ABC was hosted around 1996. As Alan said, the spirit of Val d'Isere was what Luc Picard would say every day. The only rule is there are no rules. So you could speak as long as you want about anything you wanted. And that was really beautiful. It's wonderful, but if everybody understands the limits of one's liberty, because some people would take maybe 40, 50 minutes to speak about something which would finally be not so interesting. And also it was possible until serious commercial interests entered the scene. Because at that point, when interventional neuroradiology became commercially appealing, then it was less interesting than before. So if you look at the Val d'Isere from 1980 to 2020, my opinion, my personal opinion was that we had fantastic years in 1984, 1994, since 1984 to 1994. The good years, 1995, 2000, more or less. The bad years, because of what I just told you, between 2001, 2015. And then people started to understand that it was better to try to go back to case discussions. And so there has been some improvement in the last years. In Val d'Isere, I would learn everything and all that was needed to advance with my job. Every year, my activity back home would depend on what I had learned in Val d'Isere. So I would really, every year, I would work as far as I had learned in Val d'Isere. So I believe that the Val d'Isere meeting with all its participants has had the great merit of shaping our specialty, really, in a way that makes it much more concentrated on problems and unfavorable outcomes rather than on successes. And this is really different to other specialties. Has the reform been behind the rapid growth in knowledge, in technical solution, and in clinical quality? This was Val d'Isere in 1992, and the growth made it like this in 2020. So that was just a few words I wanted to say to make people understand what it has been and what it has.
Modi, thank you. Thank you so much. Yeah, I think it's, we continue to emphasize how useful this meeting is. Like above everything else, you know, many people, of course, have gone here that have joined. But I hope that this helps spread the word, that this is, I think, a must-attend meeting for anybody who can come at least once and see what that's like. It's super unique, of course, for many reasons. And I just encourage everyone who hasn't been there, you really have to go. You don't have to ski or snowboard or do winter sports or whatever. A lot of people don't. They come for the meeting itself. It's like 8 to 12 is meeting, 12 to 4 is the break where you do whatever sports you want or anything. And then 4 to 8 is again meeting. So it's a full day of meeting. Very, very, you know, it's extremely packed with all kinds of information. Anyway, I just want to put that plug in because I it's super important that people go and experience what that's like. Please, anyone else? I know there are a lot of people that have gone, have something to say. Anyone else want to say anything?
I wanted to say that, I mean, the way we know Val d'Isere, it's really impossible to make that an online meeting, you know, like the whole like experience, like it's impossible to replicate in an online situation, I think, compared to probably the average other conference. So, I mean, have to say I'm happy it was not translated into an online meeting Val d'Isere this year.
All right. Okay. Well, thank you, everyone. If anybody else wants to chime in, say anything about Val at any point, please do. We again thank our guests for coming. Alan, Shankyu, Rani, thank you very much. If you have to go, you have to go. If you stay, you stay. Thank you so much. We, in many ways, like if Bananas I think is organized, again, it's kind of like Val. People, it's a lot of cases, a lot of discussion as much as we can. We discuss, and I think the discussion also, importantly, the discussion is around cases, and there's a mix of cases and anatomy, and we discuss not just individual cases, which is the heart of it, but approaches. Like we debate about how we look at anatomy, certainly how we look at cases, but the anatomical features, I think is an anatomical platform as well. And there's I think there's still a lot of stuff to be discovered and discussed and really worked out in that. It's not all going back to what we know and like, Pierre's school. It keeps going. So with that, anybody else, anything to say about Val? Okay, so then we'll continue. Dodi, I think it's back to you. We have Dodi has a presentation. I think it's on micro AVMs, not being just small AVMs.
Maxim, I get this line, I don't know, probably you see it on my presentation, which says something like, I don't know if that's because I'm a co-host. So you could you please
I can
exclude me as a co-host and just, so maybe I can present, let's see if it doesn't happen. Thank you very much.
You can share screen.
Okay, hopefully it doesn't happen. So you see it?
Yeah.
Okay. So micro AVMs. Is in my conflicts. Yazargil in 1987, for those who don't know Yazargil, well, go and look, but it's one of the most famous neurosurgeons who invented micro neurosurgery on the microscope. So he defined micro AVMs as subclass of AVMs. Which one? The one in which the diameter of the nidus is less than 1 centimeter. And this is the book in 1987. And all neurosurgeons after Yazargil said the same thing. So the micro AVM is the one where the diameter of the nidus is less than 1 centimeter. But why 1 centimeter? What is so special about that size? Is it such a unique AVM that needs to be differentiated from the others just because it's smaller than 1 centimeter? It's probably a surgical view on things. So it's very small, it's easier. So would you call these micro AVMs just because they are smaller than 1 centimeter? Are these micro AVMs? I don't think so. But even with this broad and unspecific definition in the literature, there are not so many cases. In 1988, Lagenia's 13 cases, but then in 2002, 10 patients. In 2013, 28 cases. Micro AVMs, or let's say AVMs less than 1 centimeter, are so few. For me, it should be a name given to something special, micro AVM. And what is it? My suggestion is this. So what is it? It's a very small AVM, of course, or AV shunt, where there is no nidus at angiography, but only a few very small connections. The arterial feeder is of normal size. The draining vein is of normal size. So how do you recognize it? Just because of the early appearance of the vein. Example, this is a 56-year-old man with a parenchymal and ventricular hemorrhage, which you can see here. So a pretty big hemorrhage. And this is the first angiogram done in a different hospital. Do you see the AVM? 6 weeks later, he comes to us, and this is our angiogram. Do you see the AVM? Magnified. Now you see a vein, an early draining vein. And that's the AVM that, or let's say the AV shunt that bled. So you need a treatment. The treatment is not easy because there is really no arterial access, very small artery going to the AV shunt. So probably the venous approach is more, is possible. You go into the internal cerebral vein up to the point of the AV shunt and inject onyx. In this case, with disappearance of the AVM, and of course the follow-up is very good, and a very small lesion in the frontal lobe on the right side. So how do you make a diagnosis? First of all, think of the possibility, because in many places and many times I've seen that, you know, there is a hematoma in the brain. I do an angiogram, I see nothing. Well, there's nothing. Not really. You just have to look with a very good angiography, accurate, no rush, many projection, many magnifications, super selective. And if it's negative, just repeat it. This is one of our first treated cases, 32-year-old man in frontal hematoma. At day 0, this is what we see. And this is the angiography, not good quality, but certainly we couldn't see anything. So there's no AVM. We repeated at day 13. See that the year is 2005, so it's really many years ago. And at this point, something was visible, so we magnified, and maybe now you can see it up there. Not immediately visible, super selective. Now you can see the AV shunt. And we decided to inject some glue. The shunt disappeared, and the 1-year follow-up was okay. Another example, temporal hematoma. This is the angiogram. Do you see an AVM? Okay, on the lateral view, it was more visible because it's right in the middle and there is nothing behind. But you see that the artery has a normal size, the vein has a normal size. It's just an early draining vein. At the time, so in 2005, 2007, our question was, is it the AVM that caused the hemorrhage? Or is it the hematoma that causes the early appearance of a vein? Because that was our point at the time. What is it? So we decided to wait and see what happens. At day 7, again, same thing. There is an early appearance of the vein. Two months later, still there. So time to go and treat it. Go there with a microcatheter, inject glue, and the shunt disappears. 6 months follow-up, of course, there's nothing anymore. What is the presentation of micro AVMs? Of incidental finding, very difficult. It's difficult to see it when you have a hematoma. It's more difficult if you have nothing. But if you are good, you can maybe sometimes find it. Usually it's just a hematoma. So in a young patient with spontaneous intracerebral hematoma and no evident cause, always think there might be a micro AVM. And look closely, search accurately, maybe repeat the angiogram. Another hematoma, where is the AVM? Not easy. So repeated the angiogram. Again, we are in 2007. Maybe today we would look for it before and we would find it at the first angiogram. But now you see an early draining vein. And again, day 50, it's much more visible. So at 6 months, we decided to go and treat it, saying, well, it's not a temporary event, it's just still there, maybe we should take care of it. And this is the super selective angiography, and again, glue and disappearance of the AVM. So the treatment, and the question is it needed? This could be a good point to discuss. Once you see an AV shunt that has caused a hematoma, which is what we see, should we take it off, or meaning it will repeat its rupture, will it rebleed? I'm not sure. We don't have a lot of information about this. Maybe not, but it's not so difficult to treat it. Open surgery may be difficult because they cannot find it. They don't see it. It's not so visible. Radiosurgery, again, it's not so easy. So for me, endovascular is the first option. Why? Because first of all, you see it and you go there angiographically and you find the AVM just because you do a subselective angiography, and then you can inject a small drop of glue if you can get there, or you could use a venous approach when you cannot. Another case in 2004, really this one, this is the emergency angiography for this hematoma. And you can see the AVM there, reaching it with the macro catheter and injecting glue. And you can see where the glue is. So the presentation is always hemorrhagic, of course, as we said. How else could it be? Well, we had a case once where it caused a venous engorgement. See here, this man with visual problems. This is the CT scan and the MR, big problem in the parietal region left. And the angiography shows this incredible shunt, which is frontal. But from there, you see the super selective injection in the frontal lobe that goes back all the way to the parietal, causing an incredible engorgement in the parietal lobe. And the same it may happen in the upper cervical cord. Remember, when you have an upper cervical hyperintensity, always think venous engorgement rather than myelitis. And even if the MR gives no signs, do an angiography and do it well, because sometimes it's really difficult to find. Like in this case, it was not so easy. Of course, we did all external carotid arteries, vertebra, and so on. And finally, you could see this little tiny vessel there, which would come pretty late at the end of the angiogram. And so where is it? What is it? Where is the shunt? To find the shunt, we started to go from below and go up and up and up, and finally find it in the lateral cerebellar location, selective angiography of the superior cerebellar artery. And we are in superior cerebellar artery, and you see now the artery, the shunt, and the vein. And the vein is the one which goes down to the upper cervical cord, so causing that problem. And we injected glue as usual with occlusion of the AVM and the shunt, and a good outcome. But anyway, so the conclusions are micro AVM. What is it? It's an AV shunt with a few very small connections, more or less what you see here. It is not a small AVM because there is no nidus, at least as we usually think about a nidus. It is not a small pial AV fistula because it's not one hole. Could it be the origin of a larger AVM? Well, I don't know, but I don't think so. We have not seen any evolution over time. Maybe we have not waited enough. Could account for the so-called occult AVMs. What are the occult AVMs? Are those AVMs not visible at angiography, but found at surgery? Sometimes surgeons tell you, well, there was a hematoma, you didn't find anything, but I went there and finally I occluded an AVM. That's good for them because they have one more AVM in their logbook, but I'm not so sure that it's true most of the time. And the take-home message is that an intracranial hemorrhage, intraparenchymal hematoma, may be caused by a micro AVM more often than thought, especially in young patients. So a very accurate angiographic study is needed. If negative, it might be best to repeat it after a few days. There are no occult AVMs, but only bad angiographies. Thank you very much. And I'm here to answer any questions, of course.
Okay, thank you so much. Okay, let's go into discussion.
I ask a question?
Sure.
Jordan. You raised a question, should you have treated those? And I think most of interventionalists would treat an AVM that bled, even if it's very small. I don't know if you had cases, but we have a lot of cases after radiosurgery where the AVM was larger originally. Actually, after radiosurgery, gamma knife or such, it becomes a small, very small residual shunt that's just a little bit early. Do you think these should be treated or just watch?
Thanks, Ronnie. Well, I think we should, because when we start treating an AVM, we decide that we give patients risks in order to have him cured. So if you, the final goal is to not have an AVM anymore. If you still have a small residual, I think you have not done what you should have done, and you kind of have had a contract with the patient. Let's go through all these terrible things you need to do in order to have you cured, which means no AVM at the end. And so I think it's our, we need to do it, yes. And usually it's a lot easier at that point. Once you are left with a very small residual part. We usually do it through a venous approach most of the time, because we think it's much more effective, and we are going to have a cure with much higher probability than going through an arterial approach.
Thanks.
Dodi, it's Kim. It was a wonderful talk, very provocative as usual. But I was really taken by the final comments on occult AVM and the whole discussion of what that is. And I guess you and I both go back long enough to understand how MR affected that, because prior to MR there was really no good way to diagnose a cavernoma. And so many times surgeons will operate on a hematoma, they find a vascular lesion, and then it's mistakenly reported by pathology as a vascular malformation, AVM, despite it being a cavernous malformation. So there is this confusion, and I kind of came to believe that angiographically occult AVMs mostly resolve to cavernous malformations, essentially. But it's critically important, as you say, to complete the diagnosis and repeat angiographies if necessary, because this is an underdiagnosed entity. I agree with you wholeheartedly in that respect. Beautiful talk.
Thank you, Kim.
I thought it is a Sunkyu. I have two questions. It's a wonderful presentation. Also, the first part, the one before, is reminding that the old days, and then the showing beautiful pictures, rare pictures. That was very good. Regarding your talk, nowadays a lot of we have symptomatic, the AVMs, even though small, based on the location and the surgical approach. I think that sometimes we decide the embolization as not the curative manner, but some adjunct to the final management. What do you think about that? Because you actually had a very dogmatically endovasculated one, right? Of course, I like that kind of the comment, but I would like to have some your thought about it. Another one is it comes to me is more problematic if the patient having actually small AV shunt type of the lesion on the diagnostic angiogram. The patient was not presented with the hemorrhage or the venous congestion. In that case, what would be your approach?
Okay, so first of all, we in our hospital we treat a lot of AVMs, and we work as a team: neurosurgeons, radiosurgeon, and ourselves. So we think we are only just one group. We are not dividing things between me and you. And the first option in the majority of patients is surgery. And the second option is radiosurgery. So we come as adjunct, as you said, and usually the first to take care of a hemorrhagic AVMs, it's us, because we think we need to find the rupture point there where there was the bleeding, and we might just occlude that. We don't care about the whole AVM, we just want to take care of the rupture point, and that's most of the time it's endovascular. And then we manage the AVM as a whole, as if it were not ruptured. And again, so most of the time it's surgical, and when surgery is not possible, it's going to be radiosurgery. What we do is to help the surgeon when he needs it. So it's the surgeon who tells us, this time I would like to have this part, which is not the whole nidus. He doesn't care about the whole nidus. He cares about specific feeders, which are more difficult for him to manage. Usually the deep feeders, the ones that come from lenticular striate, perforators, and those are the ones which we have, also we like to do it because it's fun to go into small vessels with small catheters. And we don't need to inject a lot of material because that's not going to help him. On the contrary, that's probably going to be more difficult to manage a big rock kind of thing inside the brain. That's what we do. We manage together as a team, as if it were only one person with different hands. I have a hand which is surgery, I have a hand which is endovascular, and I have a hand which is radiosurgery, and that's what we do. And the other thing we like to do, and sorry if I've taken too much time, it's to have radiosurgery before any other thing, because we have understood that surgery and endovascular is easier after radiosurgery rather than before. So we don't do size reduction endovascularly and then go to radiosurgery, but we do the opposite. We do radiosurgery first, and what's left then, if it's possible, it's going to be surgical or endovascular. About the the venous congestion, well, whenever you have a venous congestion and it's caused by an AV shunt, I think you should take care of the AV shunt, but maybe I did not understand your question, Sean. Thank you.
The question was regarding unruptured small AVM. That's perhaps the other many audiences.
Natural history of AVMs is much worse than natural history of aneurysms. Small AVMs rupture as large AVMs. Small aneurysms don't rupture as large aneurysms. So we are very strongly against treatment of small aneurysms, but we favor treatment of small AVMs. Why? Because the risk of the treatment with small AVMs is much, much lower than the risk of treatment with larger AVMs. And so the risk is small, and the advantage, the benefit is much higher because we really think that AVMs are more dangerous than aneurysms, and we should take care of them more. So even if they're small and unruptured, yes. Large and unruptured, then it's more doubtful. We might think about it, especially if they are grade 5 or 6 or 4. So in those cases, probably not. In 1 and 2, Spätzler grade AVM, yes, most of the time we tend to treat unruptured AVMs, yes. We don't care about Aruba.
Thank you.
But to your point, Dodi, Aruba did show like a 2.3 annualized rupture risk, 2.3%. So you're correct. It's more risky than an aneurysm.
But of course, you have to make your treatment low risk. And sometimes it's possible, sometimes it's not. But so we tend to think that if the risk we think it's going to be less than 5%, then we should go on and do it. If it's...
Anyone else? Questions, comments?
So Dodi, that's a very nice collection of cases. And when I was looking at it initially, I was struck that most times the angiographically visible fistula that you're showing is only visible 1-2 weeks after the hematoma presentation. And I thought maybe that was ischemia induced, and that's what we're seeing, why we're seeing the fistula late. But of course you showed it at 6 months, which is too late for something to persist like that. But I think you're absolutely right. These don't look like AVMs, right? Because there's no real nidus. It's just a tiny little micro connection between the artery and the vein, unless I didn't see the nidus properly. And the only other comment I have is that I didn't see any false aneurysm, anything that could have, clearly looked like the rupture point. All you're seeing is the fistula. Have you got any thoughts about that?
Thank you. Not really. So one might think, well, there was something that just with the rupture, it went away. And that's probably the simplest way of explaining it. I wouldn't imagine that the rupture was the cause of the shunt, but it could also be so that there is a venous rupture and something happens there. The other possibility is a thrombosis of a small venous channel which was close to the shunt and was ruptured, but it's not visible anymore. So you can of course imagine many things, but I wanted to tell you that all the shunts were visible at the first angiography. Of course, if you go back on hindsight, and so yes, they were there, but not recognized on the first angiography because, of course, because we didn't see it, but they were there.
Difficult to see, for sure.
And by doing that multiple times, then finally you start to look better at the beginning now, rather than wait for some time. So, and we find it before and we treat it immediately. Again, I'm not sure this should be done. We don't have, of course, evidence-based information about that. But still, I think it's probably better. We have not seen re-bleedings of these AV shunts, so maybe, I don't know, maybe it's not needed, but we'd still prefer to do it.
Cody and Alan, I want to go back a little bit to maybe it's just some anatomy, but and of course, I want to hold up a mirror to what you say here. For those of you that haven't joined before, the vessels are everywhere is the term coined by Dodi, here at least, maybe before you've used it. But maybe I'm looking at it a little differently, or maybe it's possible to have a different perspective. Of course, we all appreciate that we only can see what we can see. As you said, you go back retrospectively, you see some small shunt that maybe is just a little bit bigger now, but still small. But the question is, okay, everything has, like, all of our techniques have limited resolution, right? When we say that there is no shunt or that there is no nidus, is it that there is no nidus, or is it that there is no nidus that we can see? As you mentioned, as you say, and as one of our core approaches to anatomy is that everything is a spectrum, right? There's a spectrum of takeover of one territory over another. And so that implies all manner of variations. You can look at them discretely, but they're really not, right? So here you just have, like, okay, Spetzler said that. Now, can we just say it's just a spectrum? It's a tiny little nidus. We just don't see it because we don't have a dyna CT in that case, for example, a vaso CT or whatever. But in the end, is it all just a spectrum of whatever lesion that is? What do we think?
I think some of Dodi's angiography was very zoomed up, and you can clearly see a little connection directly from the artery to the vein, but no nidus. There's nothing intervening. So I think that resolution, we could say there's no nidus like you'd get in an AVM. They do look different to me, the pattern. It's not just a small AVM.
But we are still like I mean, what size vessels do we think they are? Like 100, 200 microns, maybe? Like something like that? We can go much higher in resolution, I suppose.
I would agree with you, Max. I think it's it's a spectrum of lesions, and you find simple single hole fistulas of all different sizes. Sometimes they're micro, occasionally they're very high flow lesions, and sort of macroscopic. But even it sort of comes down to, you know, the definition of what is an AVM. And I think Dodi alluded to that earlier. You know, what is a nidus exactly? Certainly in an AVM of a robust nidus, not every vessel is a shunt. You know, it's a collection of vessels that are collaterally connected that maybe go into a discrete number of shunts. And so that number of shunts is another variation in the presentation of these. I sort of like the definition that he provided on the physiologic basis, that, you know, essentially all of these lesions distill down to a low resistance pathway, you know, permitting, you know, the definition of an arteriovenous shunt. So I do think it's a spectrum, and you know, I would agree with everyone that has commented so far. I think most of these lesions should be treated, particularly once they've hemorrhaged.
But we'd have to exclude the more physiological kinds of shunt, right? So like post-ischemia, where you have...
No, I agree with you 100% on that. And I think Dodi answered that in the early stages when he said they were wrestling initially. When you diagnose these too close to a hemorrhage, is it injured brain that is shunting? And we see that in this, you know, ischemia, ischemic strokes as well. But the way that it doesn't resolve. And I think the other thing that is peculiar about these, even in the acute stage, is that the shunt is so focal, usually with damaged brain. And this occurred, you know, it was a conundrum in the early days post-operatively. You would do an angiogram in the immediate post-operative period, and there's always like this kind of marginal brain tissue where there's some shunting because of the injury sustained during surgery. So I think these are usually a little bit different in character because there's of the focality of them. But you know, that was a conundrum. And I think maybe in a more subtle way, you could ask the question too, since we rarely diagnose these lesions. I mean, all of us have performed thousands and thousands of angiograms. You know, have you ever made the diagnosis of this in an asymptomatic patient? And so that's an interesting number. I'd like to know that number. If we retrospectively looked at a lot of our angiograms, do we diagnose these you know, in the sort of clinically occult stage? And so that raises the question, does the hemorrhage cause the formation of an arteriovenous shunt? Is that possible? But going back to Max's point of like a spectrum of lesions, I think even when you examine these micro AV fistulas, one does see a kind of spectrum. Some have a small kind of vague nidus. Others appear to be a more discrete arteriovenous shunt. And I think the glue cast oftentimes defines that.
I agree with the Max and Kim's the perspective regarding the spectrum of the shunt, and especially when I do the angiogram for the HHT patient presented the symptomatic, we can find the multiple AVMs at the same time. And those small AVMs, when you see the gross finding, it looked like a single hole fistula, and the traditional teaching of the HHT is more likely single hole shunting, small one. And then if it is getting bigger, it creates a nidus like the features. So when I have a magnified view with the other microangiogram, it actually shows up a couple of the other small connections. When we do the other non-magnified view, it looked like it's a single hole fistula. So to me, that I fully agree that it is a spectrum, and it perhaps a lot affected by the resolution of our current angiographic picture. That's I think that what it probably pertain underneath of what we just see as the fistula or nidus.
I've done a lot of angiographies, and we have started to look very carefully, and with these new machines and big zooming that we have, sometimes we see veins and you have to decide if they are too early or not too early. And so is it a shunt or is it just a normal passage from artery to vein? When early is early, so to say. And it's not that easy, because the more you look, and if you start looking at very small parts of the brain, sometimes you see a vein which is, this is coming a little bit earlier than the other veins. Is it a shunt? Well, in those cases, you might need to do a super selective angiography, but you don't do it in all patients. So you just have to, well, say yes or no. But certainly there are cases where you have doubts about how early is early. I don't know what is the definition of nidus, and I don't think that we really have like a part of vessels which are different because they're a nidus, but they might just be very small connections between arteries and veins, which are this very small arterial part or venous part, which are normally in the brain, but in those cases are part of a shunt. And so they start to, become a little bit like a glomerulus. And why? But because they are like that in the real brain. There are so many vessels that if you start to enlarge them, well, those many vessels becoming larger, they become like a little convoluted part of a you'd call it nidus, but they're just normal vessels which have become larger. That's what I think, or might be. And so maybe what we see here is exactly that. So small connections, just a few. If you take those and multiply them for 100, you have a nidus.
Dodi, do you ever worry about, because you said you usually prefer to do radiosurgery first and then deal with the residual endovascularly. Do you ever worry about the effects of radiosurgery on the nidus or on the vessels actually? Do you have cases in which you felt like the radiosurgery made the vessels more fragile, and when you pull your microcatheter, it tends to bleed more?
Thank you, Ronnie. No, really, on the contrary, I would say, not from our endovascular point of view, it's difficult to say if it's, we didn't have any problems with that. But the surgeon would tell us that the vessels are more robust. And because the radiosurgery, what it's behaving like, making the vessel wall thicker. And so he's happier to operate on a post-radiosurgery AVM rather than normal AVM. So if I have anything to say about it, I would say the opposite. It's not more fragile, but it's more resistant to the traumatic part of that surgery, and maybe our also endovascularly. So we did not have this impression, and the surgeons tell us exactly the opposite.
Anyone else? Maybe just, I think it's an excellent, we had a Val discussion. I'm very, that's really like, very happy about that. A great presentation. I guess I just have one more question, like in terms of the incidence. If you look at the incidence, like what we think the incidence of AVMs is generally in the population, right? We would have to perform thousands of angiograms. there are certainly hundreds to find one like totally incidental AVM and an angiogram. And these days, most people coming to angio have already had an MRI or whatever, so you're probably going to pick up most of them like that. We have seen, I can think of one more recently that was like that, like what I think we would agree is like a micro AVM. So I don't know. To me, it's probably just that they exist. And of course, we don't discover a lot of them until they rupture because they're so small and you can't see them on anything else other than an angio. But it seems like it's probably just the fact that presentation is enriched in the symptomatic ones, and they're not going to present in other ways except exceptionally that awesome case that you showed with the congestion. That was great. But most of them are going to be hemorrhagic. Do you agree?
Of course, yeah, I agree. As you know, I'm a little bit I'm confused as usual, and I have many ideas about, you know, I don't believe in black and white, and so this is an artery, this is a vein, separation, nothing to do the one with the other, and capillaries in between. This is what usually is, but then in some parts of our body, there might be, you know, something else, which is easier connection between arteries and veins, and then they come and go. So today I have it, tomorrow I would not have it, depending on blood flow, depending on pressure, depending on if I drank something good, like, I don't know, vodka or wine, or if I didn't, if I smoked, I didn't smoke. So our body is always changing. Every minute we have new cells, we have new vessels, we have new everything. So it might happen that at a certain point in our lifetime, we have an AVM, and 20 minutes later, you don't have it. Maybe I'm saying very stupid things, but so I think I see it as you know, we have to think not something closed and separated and stable, but more like happenings, and anything can happen.
Right. I think it was in last Val d'Isere that someone, do you remember who presented? There was a series of cases that were presented of clearly de novo AVMs. People that are, and they proven by angiography. Angiograms done years ago, there's absolutely nothing there. And then there are big, not small, big shots. That's been like that. I mean, that's part of what you're saying.
Well, I was the one to present that. And my presentation, the title was Who Said Congenital? And I tried to demonstrate that AVMs are not congenital, because we really don't see it in children, we don't see it in utero, and we start to see them later on. And now we have more and more evidence, because people start to see them of people who don't have an AVM before angiographically and then have it afterwards. And this may happen at 10 years of age, 20 years of age, but we have people who had nothing at 40 years of age, and then at 45 they had an AVM. So there is no congenital thing here. And Christophe Cognard has put together a nice presentation exactly on that. And we have, I think, 4 cases like that. And he has 5 or 6 like that. So with angiograms, absolutely negative, no AVM. And then some years later, there is an AVM in adult population. So yes.
So Dr. Pierre described that very nicely. He said, you're not born with the AVM, but you're born with a genetic defect that allows the AVM to express. Something else happens, and then the AVM expresses in the brain. It's not symptomatic. Something else happens for it to become symptomatic. So you need these other events to happen. And it might be that you can have the genetic defect. You can have HHT, which we know causes AVMs, but not develop an AVM. So there needs to be something else. And there's probably something else that causes the AVM to become symptomatic, either to cause venous congestion or hemorrhage. And I thought that was a good description as well.
Yeah, I know that. And in my presentation in Val dIsere, where I described this case, so the first part was who said congenital, and the second part was who said genetic. Why do we think it's genetic? Of course, there are genetic diseases with AVMs, but that doesn't mean that AVMs are always in our genes, and we have no proof of that, of course. And for instance, the best proof is that they are not hereditary. So we are sure that there is no, except for those genetic diseases, if you have an AVM, you don't think your father, your mother had an AVM, and you don't think your children will have an AVM. So why do we think it's genetic? And there is no real reason. And the thing that saying, oh, you have it in your gene, but then you need a trigger in order to have an AVM. Well, it's a nice way to say it, but it's an excuse. I mean, it's not really shown. And there is no evidence for that. That's what I'm meaning. So why not thinking that you just may have an acquired, AVMs are an acquired disease? Why not? Like dural AV fistula. So dural AV fistula, if you think it's also an acquired disease, I hope so. Well, why not the AVM? It's the same thing. Maybe it's due to a venous thrombosis, which anybody can have in their life, any time, any moment. And then after the venous thrombosis, you may develop a shunt on the dura if it's a dural AVM, AV fistula, or in the brain if it's an AVM. Same thing. I think it's simpler to think it that way.
I guess it depends how you look at it. Because, I mean, there are clear cases of genetic AV fistulas, right? RASA1 is a gene that is passed on in families, and you do inherit the chance to get a fistula. And that's the same with HHT, is you have a gene defect that impairs the cytoskeleton for angiogenesis, and you will get AVMs in the family, or pulmonary fistulas. So we know there is a gene that codes for angiogenesis, and if it doesn't work properly, you can get fistulas. So other AVMs that look so similar, it makes sense that there might be a gene defect of vasculogenesis, angiogenesis as well. But you're right, there's no evidence for that. If you look at all the genetic studies done on those AVMs, we're unable to find the exact cause, but angiogenesis is really complex. There's so many things that are taking place at the same time. It's hard to find exactly the cause in every patient.
If I may add that the one thing is genetic, I think means there are some event happen for gene expression, and then that gene expression ends up the AVM development, which does not mean this hereditary, and which does not mean it was somebody is born with it. So that's what we know based on the current DNA and gene expression analysis. I think that's what Alan means, and then Pierre means as a genetic, not necessarily as a hereditary or born with a different or abnormal genes.
You can look in the Zoom chat. There is a link from ETW. It doesn't have a microphone, but so I've asked to comment, but there's no mic. But there's a link to an article from the New England Journal of Medicine on KRAS mutations in AVMs. It's New England Journal. It's 2 years old. Vitor Pereira is on that, amongst some other people. So I think, I don't know if you can we don't probably have time to go into the details of that, but I think it's worth looking into. Just keep an eye on the chat. Let's move on, unless there's other comments. We have some cases to go through, like 2-3 other cases if we can. Dodi, thank you again, and thank you everyone for the discussion. Mohammed, can you hear? Can you present yours?
Yeah, hi Max, hi everyone. So I'll share my screen probably from. It's taking a while.
Yeah, we see like a started screen sharing, but we don't see the slides. I think you're muted. If you want to unmute yourself, Mohammed.
Oh, hi. Yeah, I'm not sure why it's not going live. It's just.
Do you have a PowerPoint?
Yeah, I do have PowerPoint.
If yours is on PowerPoint, you can maybe, if you could forward it to me, I can show it.
Okay.
Show up on the screen, and then we'll move on to another presentation and come back to you.
Yeah, sure. Yeah, I'll do that. Thank you.
Just see if you could, I don't know if it's big enough email or somehow quickly get it over.
Okay, great. Yeah, thank you. I'll do that.
Hima, are you on?
Yes, am I audible?
Let's see if you can you show yours?
Yeah. I think the screen sharing is not working because of it's being shared by others as well. Am I audible?
I'm sharing the screen now.
Yeah, can you see the screen now? Okay. So this was basically an 8-year-old child who had presented with thalamic hemorrhage and left intraventricular hemorrhage a while ago. And the child was referred for an angiogram to look for the feeders to the AVM. This is the vertebral artery injection, as you can see. And what we had noticed when we were doing the vertebral artery injection was that this was the anterior spinal artery filling from the left vertebral artery, and the ASA was infused in this child. So that's the same left vertebral artery in an oblique projection. And we can see that the cranial component of the cervical ASA is again unfused here all across, all along its extent. If that's the delayed phase, we can see the same thing much better. We took a proximal injection to look how far we could trace the anterior spinal artery, and that's the cervical ASA. This is the cranial component which is unfused, and there is part of it, the caudal component also, which appears to be unfused. When we were just removing the catheter was consistently going towards the superior intercostal. So we just incidentally happened to take an injection of the superior intercostal. And what we noticed was that the ASA was filling from the superior intercostal, again filling the entire cervical component up to the cranial part of it. There was reflux into the cervical ASA, and we could trace the limb completely inferiorly all along the axis. That's the next injection. That's the same thing. And as we took the subsequent injection, what I also feel is that there is a part of it which is unfused also in the caudal component. And we will also see the basket filling here very well with a reflux into the, we can see the basket here inferiorly. And we could see the dorsal, the mid-thoracic reinforcements all filling very well in the same injection. So what we could see in this child was a complete filling of the entire anterior spinal axis from two injections that we took, one from the superior intercostal and the cranial component from the left vertebral artery. I also have the runs, and maybe I can show you the runs as well. There was no filling from the right vertebral artery to this. That's the right ICA, the right ECA. Of course, these did not have any feeders to the AVM. So we can see that it fills a little later.
I think you're on slide 11 now.
Is it better now?
Yeah, you're on the supreme intercostal slide, like a little bit later in the arterial phase.
Yeah. Okay. So that's the left vertebral artery injection.
Are you showing a vertebral injection? I think
Yes.
The slides, right? Maybe the
Is it still in the slides? Is it still in the slides? I do not see the runs.
Yeah, we see slide 11, which is like still the spinal, the supreme intercostal.
Okay. I'll share that again. Okay. Yeah, can you see the vertebral injection now?
Yeah.
Oh, so sorry. Sorry about that. Sorry.
Okay.
So, yeah. So that's the left vertebral artery injection. And you can see the filling of the unfused ASA here. That's the oblique injection. That's the right vertebral artery injection. We could not see any component from the right vertebral to this. And that's the supreme intercostal injection. Yeah, so yeah, this is the last injection that we had, where we could see the entire spinal artery. And I think at the mid-dorsal level also, there was a small focal duplication that we noticed in this child. I could not take any more injection because, as you can see in the last acquisition, there was some spasm that we noticed here. And then that was the point when we injected some nimodipine and we stopped there. So I just wanted to show this anatomical variant and then have your opinion on how else I could have proceeded with acquisition. And for discussion, please.
Thank you. Thank you so much. Comments, questions?
Is it possible that we're seeing the whole spinal artery because, as you said, you were in there was some spasm around the catheter. So with the injection, this is probably a relatively younger patient, and with the injection, yeah, you could have overcome the inflow from other radiculomedullary supplies, so as to see the whole axis. Is that possible? Can that be the case? This is certainly like very unusual to see almost a whole spinal artery supplying by a single radiculomedullary artery.
Yes. Yes, so before this, we have never seen it. Actually, we have also not ever injected it in a pediatric patient to look for it specifically, but we have come across a filling of the anterior spinal artery I had shown previously in one of the meetings, where we could see the entire spinal axis in those patients, but that was an adult patient which was being evaluated for, again, for some other pathology. This is the first time that we have come across the ASA filling completely in a pediatric patient. So it was the first time for me as well.
Any other thoughts? Anyone agree with Eitan? Have any alternative possibilities? Okay. I think I'm not sure, but what another alternative possibility would be, other than the dynamic one, as Eitan mentioned. What else would allow us to kind of see that? And based on the movie, it looks like there's definitely a hemodynamic component. Is that all there is to it, or something else?
No, so these are all the acquisitions that I have. Yeah. Yeah.
So I think hemodynamic, at least in part, I guess. Anybody else? Any other thoughts? All right, Kima, thank you so much.
Thank you. Thank you.
Well, if I am a drop of blood and I'm in the anterior spinal artery, where would I go? Usually I go down towards, from the head to the tail. And so if I am a drop of contrast, I would do the same. Yes, there are situations where you inject, the adunculus and you would see it going down, but then a branch of it would go also cranially. But is it just because you are injecting hard, or is it because that's the way it goes? So I'm not sure I understand the problem. So you inject contrast in the vertebral artery and you see the anterior spinal axis all the way down to the tail. Is that right?
No, actually, from when we injected the vertebral artery, we could see only the cervical component of it. But when we injected the superior intercostal, that is when we saw the entire spinal axis.
Yeah. So why not? Well, it's usually, you have different entrances to the anterior spinal axis, but in a young person, you have much more beautiful highways for blood to go, and I'm not surprised really, and it's just what I would expect in a young person when you just see, many more arteries and veins than in older people like me, unfortunately.
Yeah, thank you. Thank you.
All right. Okay. Let's see. Great. Okay, thank you. We can see the screen.
Yeah. Yes, so I'll present today. I'm interventional radiologist at Boston Medical Center. Present today this interesting case that we treated recently. So he's early 40s, and as you can see in the photo here, there's periorbital edema, red eye, and chemosis of the left eye, and this has been going on for a few months. And I'll start with the CT scan. CT venogram of the head, and you can see here very dilated superior ophthalmic vein, usually dilated superior ophthalmic vein. So as you go down toward the cavernous sinus, you can see probably the cavernous sinus on the left side. It's not well shown here, but it was a little bit dilated, but there's a lot of vessels here. So I'll show the angiogram of this patient. So this is the lateral view of the ICA injection. You can see that there is this early big venous superior ophthalmic vein, very dilated, and there are probably some feeders from the inferolateral trunk, but I think the main run is gonna be this is the AP view, but it's just the ECA. So this is the AP view of the ECA on the left side. You can see dilated middle meningeal artery with a tangle of vessels here and then draining into a big superior ophthalmic vein. Obviously, both cavernous sinuses are early. There's early opacification of both cavernous sinuses. You can see the inferior petrosal. The interesting is the lateral ECA, as you can see here. This is the ECA run. So I think this is the first thing is we really have to differentiate between where's the location of this fistula or shunt, or I don't know, probably AVM, because if you look here, I don't think the shunt is at the level of the cavernous sinus. I think it's, if you look back to the CAT scan. This is again the ECA run. If you look at it and try to see, so this is the IMAX, and you can see the middle meningeal artery here, foramen spinosum, and then you have a lot of smaller branches, the accessory meningeal, the deep temporal, anterior and posterior, and there's this tangle of vessel here, and this tangle of vessel will drain through a small channel into a much larger superior ophthalmic vein. So I do think that the shunt, or the nidus, if you want to call it nidus, is not really in the cavernous sinus, and this is important, the treatment. And then if you look back to the CAT scan, you can see that actually the cavernous, the sphenoid body on the right side, and compare it with the left side, so there is almost a lytic lesion here within. So the center of the lesion, the epicenter of the lesion, you can see it very clearly here that the sphenoid body is, how does it look on the right side, but on the left side it's replaced by a small, or like a tangle, or abnormal vasculature. You can see it here. And then this, and I'm trying to call it nidus because this is actually probably, we don't have pathology on it, but it's like multiple enlarged vessel within the bone, centered in the bone, and draining through a small vein. You can see the vein here through a bigger shunt. I think it's interesting because like the first, you can probably think of it as CCF, but I don't think it's really a CCF. And now this is also on the sagittal view. You can see this is from the sphenoid body. You can see a small channel draining into the large superior ophthalmic vein. The treatment, because it's not really in the cavernous sinus, we decided first to go through the arterial, hoping that we will be able, from the arterial side, because it's easier to navigate, and we have already the catheter there. So we're hoping that if we can get through this middle meningeal artery, you get to the nidus. Again, I'm calling it nidus, probably it's not true, but we'll see. And then if we inject from here, from this nidus, you will see, we can see this smaller channel that we saw on the CT scan, and then it's draining. So ideally, or theoretically, if we're able to get this shut, we probably can get rid of this fistula or vascular malformation. We tried to inject onyx from this point here because it was very close, and this is, again, this is the middle meningeal artery, so we are not really dealing with accessories. There's always like potential connection with the ophthalmic artery through the meningolacrimal, but we were distal. Again, the ophthalmic artery was beneath this vein, so we tried to inject onyx from here, hoping that the onyx will really go into this foot of the vein here. Unfortunately, we didn't have a septor or mini-septor balloon, so onyx kept, refluxing back even after 30 minutes of injection. And then we decided then, after trying from the arterial side, we decided, okay, probably we should try the venous side. And as you can see here, the venous side, they can have the inferior petrosal sinus here, the cavernous sinus. You can see the shadow of the ICA here, or you can go through the facial, either direct puncture or through the facial vein. This is a little bit tortuous, so we decided to give it a try from the venous side, from the IPS. And as you can see here, so this is the inferior petrosal. This is probably the junction with the jugular bulb or the jugular vein. This is the inferior petrosal, the cavernous. It's a little bit tricky. That's why we didn't try venous initially, because it's, a lot of probably the catheterization. But it was very interesting because it was really very fast. So you can see here, this is from the arterial side. You can see the onyx, the MMA embolized here. But this is from the venous side, the guide catheter in the IJ. This is the microcatheter through the IPS, and this is through the cavernous sinus. And then again, we're aiming, or we're targeting this foot of the vein between this tangle of vessel and the dilated. Again, I don't think we should really target this big vessel, because this is not where the problem is. I think the problem is here. So it was not very difficult. So you can see here the microcatheter, the wire, and then we get to the real foot of the vein. We put actually, we started some onyx here. And again, this is really distant from the cavernous sinus, which is here. And you can see it's relatively safer to inject onyx from here. Again, just to compare, this is the microcatheter from the venous side. You can see it through the cavernous sinus, through the tuft of the vein, compared to the microcatheter from the arterial side through the MMA. So again, this is very close, but unfortunately we couldn't get it from here. So we decided to do it from the venous. And then it was very, very easy. Just inject a little bit of onyx, not too much probably. It went inside the nidus or the sphenoid or the intraosseous hypervascularity. And then when it got to really the foot of the vein posteriorly, you can see here, and then it shut down completely. You don't see anything from the ophthalmic artery, from the ICA, nothing from, and you can see here the MMA a little bit, sluggish flow. So I'm interested to hear about, like, what do you call this lesion first, and if anyone would have done anything differently. The patient, this is again before and after. Is just when you got rid of this small target here, everything shut down completely. And very interestingly, that the patient, and this is the onyx from the arterial side and from the venous side, the patient the second day has completely, probably see a little bit of redness, but everything has subsided, and he improved clinically very rapidly. So this is my case.
Mohammed, thank you. Okay. Let's open up the floor.
Mohammed, that's a very nice case. Thank you.
Beautiful.
I would call that lateral sphenoid wing osteodural fistula.
Mm-hmm.
I've seen one or two examples, not all of them draining like yours through the orbit, but actually others draining into cortical veins, the Sylvian veins from that location. But I think your treatment was absolutely perfect, very elegant, very nice to get to the bottom of the fistula and close it off with the onyx. I think that was very nicely done.
Thank you.
It's a beautiful example of targeted embolization, right? So I think the most important part of treating dural AV fistulas is to look at it for a few hours before you go in and find the spot that you have to be at. Otherwise, it becomes a bloodshed situation of embolizing and hours and frustration, and eventually you will close it, but with much more effort. And this is a beautiful example of the work has to be done before. Now we have nice tools to actually evaluate fistulas, also with the CT, that you get from your endovascular injections. You can look at it, as you showed very beautifully, and understand where the fistula point is. Very, very beautiful case.
Thank you. So my other question, sorry, go ahead.
No. I just wanted to say I have nothing to add. I just wanted to say beautiful case. Thank you very much. Very good.
Thank you. So my question is, if you're treating from the venous side, how far do you go? Like, is it just sufficient to just treat the foot of the vein, and then do you wait to the reflux into the nidus, or I'm calling it the nidus, probably it's not the true term again, but it's just sufficient to just close this shunt or this foot of the vein? Do you have to shut down the whole arterial feeders, like from the venous side?
And that is something I wanted to say. I mean, the case is fantastic. I'm not sure. Personally, I wouldn't use the word nidus here. I mean, there's a fistula. It's a fistula point. You pointed that well with that arrow, like on that coronal CT. There's a fistula. It's a dural fistula. You close the hole, you close the fistula. Now, it probably doesn't hurt to inject some onyx and close some of the feeders. But I think this is a location where that can cause issues. So, I think in this case, it's probably enough to close just the foot, and you can check with you close it. Maybe you keep like a distal access, you close that foot, either maybe with 2 microcatheter if you're unsure, and you inject through the artery and you see if you have the residual fistula. And probably the answer is no. So then you can.
So one Tibor here. One consideration that comes to mind is how much of the symptomatology is related to the fistulization versus the just the arterial/venous engorgement. So if you
arterial engorgement, if you cure the fistula by closing that the fistulous point, those will shrink, right?
I know that. No, but what I'm saying is, let's say you have a critical intraocular pressure issue that you have to deal with. So, I don't know. I would probably go on the arterial side as well and just give a little bit, not because I don't think the fistula, purely speaking, the fistula, I think, is closed when you close the fistula point.
The way Mohammed showed, it seems a single hole fistula. And, you close the hole, you cure the fistula.
Yeah, no, I agree. I just don't like to believe that all these big engorged arteries, I don't know. I'm probably wrong.
Yeah, no, I agree with you, because if you look here and, I don't really think that it's purely dural fistula, as you're saying, because look at the bone, you're definitely losing a lot.
But this we have a conversation. We have actually Val dIsere like last year, where okay, these are feeders to the fistula. They go through the bone because it doesn't matter. Like the feeders can go through the bone in order to reach the point of fistula eventually, right? Like they do that in also other sites. Like they do it in the sigmoid, in the
spine
region. They do it in the cavernous. You see this a transosseous feeder from the ascending pharyngeal. So, these are transosseous feeders. It doesn't mean that the fistula is there. They go through the bone to get to the fistula point.
But we do want to go back to Alan's original comment of osteodural, because the discussion in Val, if I remember, centered exactly on that. Like, okay, there's like 1.5 zillion transosseous feeders from every occipital artery to every sigmoid dural fistula, probably, right? The counterpoint that was made to that, and that's like kind of like been our suggestion is to call it dural because these are dural feeders. But the counterpoint was that the vein is actually, like, is the vein a dural vein? Is it a diploic vein? Like, where is the actual shunt? There are people that believe that the shunt is actually in the bone, like this, all of this construction you see here, or whatever you want to call that. So that's, I mean, that's maybe like not too relevant to the treatment, perhaps, but the question is, like, these osteodural fistulas, there's not a lot of literature on them, I think. We discussed them, but is there like a coherent body of literature for that? I don't know.
But the other thing to think of is, what if there are more venous, that if you just treat one of the venous foot, what if there are another venous that you probably don't see, but when you occlude this one, this arterial feeders will open in a different one that you initially didn't see, right? And you're probably always, like, afraid of intracortical venous drainage.
For every, in our experience, most of these kinds of fistulas, I mean, these are very rare, but others too, they're usually a couple, maybe one hole, maybe a couple of holes, depending on the complexity. Here, like you nicely showed, there's one hole, and you will know when you close that hole if there's any others. There's either going to be a shunt or there won't. After that,
right?
Here, like, there isn't. The concern
So Mohammed, when we operate on these, we just put a clip across the vein. And we're putting it a lot more distal than you achieve endovascularly with your onyx. And that cures the fistula. And I've never seen one come back. I can think of 2 examples of petrous vein fistulas that we clipped, where there was an alternative venous outflow into the lateral mesencephalic vein because our clip was too distal. But you can see it on angiography and just reposition the clip. But I don't think it's necessary to keep filling it to penetrate the entire arterial feeders. You can, from the venous side, you just need to close the vein.
Yeah, I totally agree with Alan, because we would have treated this case with coils, not using liquid hemolytic materials, which I think would work also. And speaking of where the shunt point is, I think it's related to what we call the sinus of Lester's sphenoid vein, or it may be durals in a way, but I think it's more inside the bone. So this sinus is supposed to drain part of the bone over there. So it can be related to the bone, or a little bit closer to this, this sinus of the Lester's sphenoid vein. So we can treat it like we do with dural fistula, just occlude at the foot of the vein. So we would have used the coils. So I totally agree with Alan.
Yeah, well, actually, we started this vein with some coils, so I didn't show it here actually, but you can see here, after we got to this point, we put coils here. You can probably see this is the coil here, but it was a little bit, it's very difficult to control it. It's just, start like looping here, but that's why we shifted. So you can see here probably one of the coils starting to loop here. Yeah, it's very interesting because, we're trying to avoid onyx if we can just get it down by coiling. It was, that's why we started, but it didn't go very well. So that's why we shifted to onyx. But yeah, I think that's very because we always try to avoid onyx, right? Never see, the vessels are everywhere, right? So
I think another important point to make, and we all take it, it's clear to us, but maybe less to younger audience, is that the difference between dural AV fistula and brain pile AVMs is that in dural fistula, you actually want to occlude the foot of the vein, and you don't worry that those dural suppliers are going to bleed. While in a brain AVM, it's a completely different situation. If you take the vein before you take care of the nidus of the arterial side, you're going to have a disaster on your hands. So it's in a way a simpler situation. However, you have to scrutinize the images and find the foot of the vein. But the moment you find the foot of the vein, I agree with Ellen, and you take care of it, it is very rare that the fistula will come back. It's only if you take just proximal feeders, then arterial feeders, that's when the fistula is gonna come back.
I also want to emphasize, as Ronit said, I think it's about safety. Like all of these super selective embolizations that Ronit, like we're talking about, these magic bullet cures, they're usually transvenous, because this thing is very vulnerable on the venous side. Like you put a little bit of embolic there, I mean, you need enough, but like oftentimes it will close. And I think the venous approaches, these super selective venous approaches, the advantage is safety. Like these arterial, what you did in the artery, I think is perfectly acceptable. And as you mentioned, there are connections to the orbital system, and not just through the, the lacrimal artery. Dodi will tell you there's many other, and there are other connections along that sphenoid wing, the artery of the sphenoid wing. There are more proximal connections that we see to the ophthalmic system. So the arterial approach, especially when like onyx is refluxing and you're pushing more and more and you're trying to get to it, I think the danger is that you might actually end up in the orbit by one of many ways. Whereas the venous approach is much, much safer. And the less you permeate those retrograde arterial feeders, once you close the foot of the vein, I think the safer it is for a dural fistula. So I would completely agree with just very, very selective, targeted venous occlusion.
I agree with everything, but I would like to just add something about occlusion of the arteries in dural AV fistulas. I think that, and what we have done in the years is that when you have a high flow fistulas with a lot of arteries going into it, of course you can occlude the vein and leave all the arteries open. That's okay, you probably occlude the fistula. But once you have occluded the fistula, there are a lot of arteries which are there and a little bit angry, a lot of blood not going anywhere. And sometimes this causes an inflammation, an inflammatory response. And that can lead to some consequences which I don't like another fistula or symptoms or whatever, sometimes maybe hemorrhages in other points. So I like to take also some of those big networks of high flow vessels, arterial vessels, just to avoid and to how do you say, have an ischemia of the region, which probably helps to cure the whole disease rather than just going only to the vein, which is okay for the fistula, but less okay for the whole region. In this
Thank you,
case,
Dodi.
though, I agree with what you have done, absolutely.
Thank you, Dodi. That's a nice array of what I was trying to say, which is, again, my feeling that you want to take some of those, the big arterial feeders down just because of the congestion of blood in the area, which may not be, desirable.
I think the other just main message is just because someone may, oh, well, let's just like the classical CCF, just shut down everything. I don't think this will just exacerbate the symptoms of the patient if you just, if you want to put coils or anything in the whole dilated thing, because especially for, it will be more dangerous, I think, will keep the mass effect on the orbits and the eye. And it's not going to necessarily get rid of this and I think this is very important. I think this is one of the message here that it's really different than CCF, especially for diagnostic neuroradiologists or for the someone who's just starting. It's very different to differentiate and to look where's the shunting or where the foot of the vein or where this connection.
So I would like to make another point, Tibor, again, and I apologize. I'm not trying to hurt anybody's feelings or insult anybody, but I just recently saw a case that came to us after a major institution kind of omitted to look at the most obvious natural collaterals to a fistula situation that led to a false complete occlusion of fistula with a repeat angiogram a year later, again missing to look at the number one natural collateral and the fistula then rupturing a couple of months later. So I would just like to point out the importance and re-emphasize of what Ronit said. This is not a situation where you want to rush into things. You know, it's just not one of those where you do an angiogram and once you're at it, you also select some artery and put some glue, and then, you know, you have to really do an angiogram. It better be a good angiogram, not with a tiny pinhead in the center of the screen, you know, and inject all the vessels that are potential sources for flow, for supply. And then you have to understand which are your best options and make up a strategy. And then when you finish your strategy and execute it, you don't just do an injection, for example, of a dural fistula in the transverse sinus. You don't just do an injection, control injection after an occipital artery onyx injection. You don't just do the control angiogram from the ipsilateral external carotid artery, but you go to the other side and so on and so forth. Again, I don't mean to insult anybody's intelligence. You would think that it doesn't happen in 2021, but it does, even in major institutions. So please, people, keep in mind.
Well, thank you. Anybody else? It's great case and great discussion.
Thank you.
Go on, but thank you very much. We're getting close to 10, so I don't know if we can maybe stay a little longer, or Luca, what do you think? Should we table it February? No, is around. We had one more case. Let me see. Luca, if you can hear me, let us know if you want to present.
Yes, I can hear you. We have enough time.
What do you think? We can stay a bit longer, I think. If depends on what you think about the case, or we could do it next month. Up to you.
I think I can close it in 5-6 minutes if I rush.
Oh, well, okay, let's go ahead and let's see.
Okay. Good evening to everybody. I don't know if you can share the screen now.
Yeah, we can see it.
Started, yes, okay. Thank you very much to Maxime and Eitan and Kim. It's always incredible, this session and this meeting, inspired by Val dIsere. And this is a case of middle-aged man that has some medical problems, but he came in our hospital with the neurological disturbance, gait problems, and progressive lower limb paresis. He did an MR in another center, and this is what the MR showed. I show you slowly. You can appreciate
myelitis.
What?
Myelitis.
Yes, for sure. With a lot of vessel around in the posterior subarachnoid space. Give you more a T1 on the left side and T1 with contrast medium after fat suppression. Seems to be something calcification on the hemorrhagic part with the other parts with the contrast enhancement. The axial view is not so good because the patient moved a lot. In any other MR that he did, just in the axial view, I don't know why, but maybe there is some connection with it. And on the left, the T2, and the right one, the T1. I go on. There is a fat suppression on the left side. Pay attention to this axial image in the foramen of communication. And this is, the next is with contrast. We can see more, but maybe this is the lesion with the contrast. What we can say about it, frankly, I don't know exactly. We thought that it was a solid lesion with multiple components, obviously with perimedullary vessel that attract my mind, but no myelopathy, and with a partial huge enhancement. And we know that he had a progressive clinical evolution of paresis. But we can't understand exactly if it was inside the medulla or outside. We did an angio, the first, in the middle of the summer, and there is not exact projection and good magnification, but you can see quite clearly in a spinal arterial artery, maybe just above the lesion that it's here where you see the clip of the for the epiglottic tumor that the patient had. And maybe if you look attention, you can see even the perimedullary vein, the anterior one and the posterior one. So this was quite interesting more. This is our perimedullary vein again, I think the posterior one. This is the vertebral of the opposite side. And you see again, maybe a supply of the spinal anterior artery, maybe above in the upper part of the cervical medulla, a magnification, you can see. But doing a cervical, an injection of the subclavian, something changed or something relieved itself, show itself. And my colleague did a super selective, was Dr. Barletta, super selective injection. And you could see something that I never saw in my life, but this is not important, but it was quite strange. A tanglet of vessels joined together that comes inside the foramen of conjugation, and then inject this strange lesion that drain in the perimedullary space anteriorly and posteriorly as a fistula. A magnification, I'm sorry for the anesthesiologic tube is exactly in front of the lesion, but quite very, very, very interesting for me. Maybe you have seen a lot of this, but was completely surprised looking it. It seems to have a little spot with contrast in the center. This is an oblique view. I want just to show you because there is not a big magnification, but you can see the length of intra-extradural part of the lesion and then the drainage. So doing the angio, what you can say more? That probably the lesion is extramedullary because the support of the anterior spinal artery doesn't give blood to the lesion, but it's intra and extradural, seems to me, and draining the perimedullary space, and then anterior spinal artery was normal, and again, the venous drainage of the medulla was normal. Absolutely strange. So it was scheduled for surgery, but on September, he had a thromboembolic complication with pneumonia and other problems, medical problems. So we can't do the surgery, but we scheduled an endovascular treatment. I want to show you just the cast of DMSO material. There is not quite more information in the angio. And this is the last run after the treatment. So this is the cast of the DMSO material in the deep cervical artery, in the part in the intra-extra foramina and in the center of the lesion. The run at the end showed a complete resolution of the shunt. The patient but doesn't improve and comes back after some weeks of rehab on September. He repeats the MR. You see up the first MR and down the follow-up MR. We've shown more that vessels are shrinked down, maybe disappear. So it was not the shunt that gives symptoms to the patient. No myelopathy, this justified the absence of myelopathy. And this is the T1 after contrast, if I remember. No, maybe without contrast, pre and post. We did a CT scan, and this is the cast of material, DMSO compatible. And maybe you can see here the medulla that pass through laterally. And the calcium here, I don't know if it's calcium, but just the hyperdensity of the lower part of the lesion. On the sagittal view, the same. So we repeat the angio. I passed maybe after 4 or 5 weeks after the first treatment, and you could see just a little remnant of the shunt, but not so evident. We did a more selective angio, and you can see more the vessel passing through extra intradural of the lesion. Then again, the capsule and the venous drainage. We repeat the angio of all the vessel, and this time you could see very well the spinal anterior artery, the pass side by side to the lesion, just impressed by the lesion, and the upper part of the spinal artery, again here. And you could see more and more better the venous drainage. So it was not a lesion inside the medulla. This confirmed the first impression. But we need to do a step back and looking at the anterior spinal artery before the treatment. And you see, it was like this, the first injection, maybe not perfect, but enough to see the artery. And if you see the micro catheterization and super selective angio, I believe that this, with the end, with the eye of the end at the end, it was a supply of an anterior spinal artery, just come from the lesion. Why I say this? Because this is an oblique view from the left side, and you see better that this could be a supply for a radiculomedullary artery for the anterior spinal artery. And on oblique view on the right side, this is exactly probably in front of the medulla. Here, I suppose, obviously. So after the endovascular treatment, the scenario was different, and all this part of the anterior spinal artery comes directly from the usual supply from the right vertebral artery. The upper part of the spinal artery comes to the left vertebral artery, but looking with attention, you can see here other supply from the lesion here, but more lateral. Strange. So there was still a remnant of supply from the deep cervical artery and from a branch from the left vertebral artery. But now what we could say, again, after the treatment, the lesion was more homogeneous and there was less perimedullary veins, no myelopathy. But the angio confirmed that the lesion was extramedullary, intradextradural, with perimedullary venous drainage, normal anterior spinal artery. But what about the left lateral artery and normal medullary venous drainage? How to solve this enigma? What is it? We go for surgery. And this is what our Dr. Bernucci found, our chief of neurosurgery, opening the dura. On the right side, there is the head. On the left side, there are feet, T1 roots, C7 roots. And what is this? White, round, the dural sheets. First surprise, this was a neurinoma, doesn't found by the MR, along the posterior T1 right posterior roots. This was the neurinoma. The violet one, but the red one maybe, is our lesion, and the gray one is the medulla. Sorry for the design made by my children. This is the resection of the neurinoma, and this is the field of surgery without the neurinoma. Again, this is the medulla, and this is the lesion. This is the T1 of the left side, and the resection was like this. It seems to be like a big beam, brown. The surgeon leap and create an excision around the lesion. And we do a fluorangio, but we lose the arterial part, the starting of the injection of the lesion. This down is our medulla with the perimedullary vessel. Maybe this is the pedicle where the veins from the lesion comes into perimedullary vessel veins around the medulla, lifting the lesion and going around. Maybe down here you can see the dura, and this is looking behind this is the root, but not exactly the root. This is the lesion intra and extra dural that passed through the dura and going through this lesion. Okay, the movie is going to end. I want to show you just like this the root. This is the surgery, the removing of the subarachnoid. Okay, sorry. And I flipped the images of the angio just to compare the surgery field with the angio. So this is the right deep cervical super selecting injection, flip down in two direction. Maybe you can understand more than my words. And this is the intra-extradural passage of the lesion. The lesion in extramedullary and all the other things like perimedullary veins. At the histological examination, it was an hemangioblastoma, and in the fact that it was extramedullary was along the roots of the C7 of the left side, and was intra and extradural. I looked for the literature, and I saw not so much cases, but I never see the angio images. And looking more paying attention to the images, I saw that maybe this tiny vessel coming out from the root is this. That could be a radicular medullary artery. I don't know if it's exact or just my fantasy. So the surgery ends with the clipping of the pedicle where the veins comes in through the perimedullary vessel, the removing of the big beans, the cleaning of the root. This is C7, and the clip of all the vessels passing through the intra and extradural. This is the end of the surgery with all the surgery field cleaned, medulla and T1 and C7. But unfortunately, the patient doesn't improve. We don't know exactly why. After 1 month, we did an angio. We repeat the angio just to see that all the scenario is cleaned. I don't know if these vessels are supplied for the posterolateral artery of the left side that maybe is inconstant in people, but in this case could be the main supply of this lesion. And we don't know. I'm not sure about it. We need more good angiography maybe in the next phase. We confirmed that the anterior spinal artery and the venous of the medulla was completely normal. And in MR, you can see just a little bit exitus of myelopathy, area of myelopathy here, but no residual, no other problems. And this is the end. I don't know. You are sleeping?
Luca, thank you. No,
You're welcome. Thank you to wait.
Thanks. It's an awesome case and deserves time to be presented to show like all the.
I don't know if some other people didn't. And I did in my life in Niguarda a couple of angiography of hemangioblastoma, but I never saw things like this. So I was completely surprised, and I think this was very interesting.
Yeah, I think it's very interesting. That was my looking at everything. I thought probably was going to be him, but just I guess statistically, I don't know. We like all of us have seen a few of them like that. Not exactly like that, but I mean, it seems like that's kind of like what.
See, yes, you've seen it.
Yeah, we've seen one. We've done a couple of preoperative embolizations, like mostly particle. If it's like that, if it's more posterior, then it's going to recruit like hopefully like post some kind of not anterior spinal supply. Although like you really nicely showed that, of course, like there's all these connections, the radiculomedullary vessels. You might not see them, hemodynamic, whatever. But we always have to be. The point is we have to be careful, right? Nicely embolic stopped like more proximal, so even if you didn't see it, like it was nice. But we did a few like this. We did one standalone embolization in a guy that like just didn't want surgery for like some complex psychological reasons, but he was having a dural fistula kind of presentation from all this congestion of this crazy like sacral hemangioblastoma that was decompressing into his head. Like the venous drainage went up all the way into his foramen magnum. Just how like, so it was like basically that same idea. So we did like a standalone embo, like I think you do more of that probably in Europe and elsewhere than we do for meningiomas and whatever. So we saw one of those, but it's an awesome case.
That's all, folks.
Any comments? Anything? Thank you. I know we're a little bit over time, but most people stayed. Thank you so much. I want to thank everyone for coming, and Alan, Ranit, Shanku had to go to work. But,
Thanks so much.
Thank you very, very much for coming, for participating, for being part of this. We love the session. I think for me, I did. I hope you did too. So we record all of them, so we'll have like a recording online of these on whatever you'll see through the website. And again, everybody, we'll see you in a month. We'll announce the topic maybe in a little bit what we're gonna do next month. Thank you, and stay healthy, stay safe. You know, we hope for a brighter future. Thank you so much.
Bye, everybody. Thank you.
Bye-bye. Next time. Bye.